Good afternoon, everyone. Welcome to this afternoon's webinar. This is Lori Smetanka. I'm the Executive Director here at the National Consumer Voice for Quality Long-Term Care, and we're happy to have you join us today for our webinar, which is the effects of the opioid crisis on residents, points of advocacy. We have a few housekeeping items to share with you before we go ahead and get started. First, this webinar is being recorded so that you are aware of that. All of the lines will be muted throughout the presentation. We will get to as many questions as we can at the end of the presentation this afternoon, and you can type your questions in the question box on your control panel. There is, or there will be, if there's not quite yet there, but there will be a link to the PowerPoint that we'll be going through during today's program in the chat box of your control panel. The slides and the recording will also be sent out afterwards and will be made available on the Consumer Voice website after the program as well. So there will be ways for you to get the materials. So with that, we're going to go ahead and get started. And Katie, if you'll move to the next slide, please. So first of all, I want to introduce you to the Consumer Voice. We are a national nonprofit advocacy organization located in Washington, D.C. And the Consumer Voice advocates for people receiving care and services at home, in assisted living, or in nursing homes. We work by educating and empowering consumers. We advocate with and on behalf of consumers receiving long-term care and services, as well as their families, caregivers, and other advocates who are working to seek and achieve quality care. One of the things we're very proud of is that we operate the National Long-Term Care Ombudsman Resource Center through a grant by the Administration for Community Living. And through that, we provide training, support, and technical assistance to long-term care ombudsman programs across the country. Next slide, please. So you have all seen in the news and in reports that we are facing an opioid crisis in the United States. In the past, in about a 10-year period, the usage of opioids has quadrupled or had quadrupled. As many of you know, opioids are very strong medications that have been used primarily to treat pain. And what has been found is that people that have been taking opioids can develop a strong dependence or addiction to them, which can result in serious medical issues and can deal with other social or other types of challenges for the individuals. We have some of the commonly used opioids in the box that you have in front of you in the screen. Hydrocodone, tramadol, fentanyl, those are some of the most commonly used opioids. And why is it that we have this crisis right now? Well, there have been changes in prescribing practices of the use of these medications as a response to trying to control pain in individuals. In the 80s, some of the research has shown they were primarily only used after surgery, for example, or for serious illnesses like cancer or other very painful and life-threatening illnesses. But with relaxation in prescribing practices, it resulted in a greater use and prescribing of these drugs to deal with pain. And that, in a sense, led to a higher increase in their usage and maybe not as much monitoring of how long they were being used by individuals and how frequently they were being prescribed. And because they do have tendencies to cause dependence or addiction, that has been part of the reason for the result in the crisis that we're facing today. So we're now, because this has been recognized as being very problematic in this country for many people, we are seeing changes in prescribing practices again. It's much more restrictive. Changes in the way the drugs are being used and how often. And we're also seeing greater information and resources being made available to prescribers, to physicians, as well as to people using and needing the medications. in terms of how to manage chronic pain that may not involve the use of opioids, or may look at alternative treatments or combination types of treatments that could be more effective, which hopefully will then decrease the reliance on these drugs. But many state governments and local governments, as well as the federal government, have taken this very seriously, and we see that a lot of really good information and resources have been made available to work to start combating this issue in terms of changes in practices and recommendations for more effective treatments of pain. So next slide, please. So not only have we been looking at an opioid crisis just generally, but as we look at the use of opioids in older adults, we see that some of the same challenges have occurred. Older adults have long been prescribed these drugs to cope with chronic painful conditions such as arthritis or fractures or post-surgery degenerative joint or bone issues that they may have. And the thing about it is that because older adults process the drugs differently than maybe the younger population, there are also increasing concerns about the way that the opioids will affect the individual and what that impact has been on them, including issues with sedation, adverse drug events which cause falls, that could lead to fractures and other issues, and also the drug interactions, because as we know, many older people are taking multiple drugs, and if not being carefully monitored, the interactions between the opioids and other drugs could be really challenging, and also could interfere with pain management. So we know that that's been a problem. What we have also seen is that in older adults, the opioid use has been more long-term than in some with the younger population. And while many studies have shown that there is not a long-term effectiveness for the use of opioids, there are concerns with how they are affecting and the side effects that exist for people with older adults, and how they are interacting with their quality of life. So next slide, please. So we also wanted to look at and talk about the opioid use in long-term care facilities. And what the data are showing is that the use of opioids in long-term care facilities is twice as prevalent as in community settings. Oftentimes, as we know, people go to the hospital first before going to a nursing home or to an assisted living facility. Oftentimes, they're started on an opioid in the hospital, and that then carries over into the long-term care facility. Often the folks are just left on those drugs to treat any pain issues that they may be having. And so there have been real concerns about the use of opioids among residents in long-term care facilities, not only on the pain issues directly and the potential for dependence or addiction with the drugs, but we're also hearing more issues related to drug diversion both in communities and in long-term care facilities, and what that impact has been on the individuals that are receiving the drugs. We're also hearing that there are not always alternatives that are widely available for that are successful in managing the pain for the residents of long-term care facilities. And that pain, as we know, is generally undertreated regardless of what type of pain medication has been prescribed for them. So it's been a long-standing issue that pain in residents has been undertreated, and that has been a very serious concern. What some of the studies have been showing is that up to 60% of nursing home residents are in persistent pain that they need some relief for, and that in a recent study of the prevalence of opioid use in long-stay nursing home residents, nearly a third of them were prescribed opioids during the study period, with 1 in 7 being prescribed opioids long-term. So these drugs have been widely used in not only older adults, but particularly in residents for long-term care facilities. And so it was an issue that certainly needs more research and more discussion, and was something that we at Consumer Voice and the Ombudsman Resource Center and with some of our partners were really interested in looking at more carefully. Next slide, please. So we wanted to, we took on this project over this past year to look at the impact of opioid use on nursing home residents. What is it that nursing home residents know about the opioid crisis? What are they saying about the use of opioids? What is it that they need or want to know that could help help them achieve better quality of life or quality of care in their facilities? Because as we were looking at the research and information that was available, a lot of it was quantitative or qualitative data and studies, but not much was related to hearing directly from the residents themselves and from their advocates in terms of what some of the primary issues were that were being raised. And so the National Ombudsman Resource Center and Consumer Voice have been working over the past year. We did a questionnaire with long-term care ombudsmen asking about the complaints they have received related to opioid use and what that information was showing. We also did a series of dialogues with resident councils across the country where we went into nursing homes and actually talked to residents and asked questions related to what they knew about this opioid crisis, what the impact has been on their lives, their quality of life and quality of care, and also what types of information they wanted to know. And one of our partners through this project is the National Center on Elder Abuse. And with that, if we can move to the next slide, I'd like to introduce you to Eden Ruiz-Lopez, who is the Assistant Deputy Director within the National Center on Elder Abuse, and she's going to talk a little bit about who they are.
Thank you, Lori. So the National Center on Elder Abuse is located in Los Angeles, California, and it's one of 27 federally funded resource centers, just like NORC. Our expertise lies in providing members of the public and professionals with the information that they need to detect and prevent elder abuse. What we do is disseminate a wealth of research-based resources and tools. We conduct education and training opportunities, and we provide the latest policy updates and information on best practices. We've had a long-standing interest in learning more about how opioids have impacted older people. So in 2017, we launched a survey through our listserv, which assessed the mounting impact of opioid misuse. It taught us a lot about common scenarios that, for instance, Adult Protective Services, Department of Human Services, and other professionals were witnessing. We heard from a bunch of states across the country, most often from Wisconsin, Missouri, Indiana, and Ohio. And some of the common themes that emerged were older people becoming increasingly more reliant on medications, and children or grandchildren stealing jewelry or pawning items for money to get drugs. So earlier this year, when we connected with Lori and Consumer Voice, she proposed this topic of having us collaborate on opioids and assessing residents' perceptions and the professionals that serve them. So this made absolute sense, given that there's so much attention focused on this topic by the federal government, and we really had a mutual interest to learn about how it's impacting people in long-term care settings. And, you know, honestly, we've learned so much from Consumer Voice over the years, and we look forward to continuing our partnership in the future. And this work is certainly pointing us in the right direction. Next slide. Since we're focusing on this topic today, I thought it would be helpful to provide a quick highlight on some resources that might be of interest. The NCEA partnered with our institution at the Keck School of Medicine of USC's Geriatric Healthcare Collective program to develop these fact sheets titled Opioid Pain Medicine, What You Should Know About, in both English and in Spanish that are available for you to share with your communities and organizations. We'll also be launching very shortly a pre-recorded lecture from medical providers that aims to teach them about how to manage pain in an older patient in the midst of the opioid crisis. So please be in contact if that's anything of interest. And I can also provide links at the conclusion of my spiel for the NCEA. Next slide. Next slide, please. Thank you. At USC, we have a number of projects that are all an offshoot of what we're doing with the NCEA. If you haven't seen our resources or websites, we encourage you to do so. First and foremost, of course, we have the NCEA website link here and the USC Center on Elder Mistreatment. One of our most recent initiatives that we launched, Supports and Tools for Elder Abuse Prevention, was created, and we developed customizable and downloadable tools to promote awareness on the topic of elder abuse, neglect, and exploitation. We also have TREA, which houses over 280 sets of training curricula that are all free to access, and you could either use them for self-directed learning or to educate others. And finally, EAGLE is a very comprehensive online module that was initially designed for law enforcement, but it's useful for anyone going out in the community who may have or have a need to access local social services, information about legal statutes, evidence collection suggestions, and there's also featured roll call videos. So I'll go ahead and turn it back over to you, Lori and Jamie. And once again, I just want to express my gratitude for having the NCEA involved in this project. Thank you very much.
Great. Thank you so much, Eden, and thanks for your partnership on this and many other important issues. And we will share afterwards your fact sheet that you shared and some of the links that you talked about as well, so that folks can also have access to those. So as part of this project, as Eden said, we partnered with the National Center on Elder Abuse, but also received funding from the Administration for Community Living to conduct this project, and we thank them for their support. And primary part of what we did as part of this project was to do a questionnaire of asking long-term care ombudsman programs about the complaints that they are receiving. And with that, I'm going to turn it over to Jamie Freshy, who is a consultant with the Consumer Voice and the National Ombudsman Resource Center, who's going to walk us through the results of the Ombudsman questionnaire. Jamie?
Thank you, Lori. I appreciate that. And so, yes, as Lori mentioned, I'm going to be talking about the results from the questionnaire that was sent out to long-term care ombudsman programs throughout the states. And so state and local ombudsmen completed the questionnaire in 34 states, and there was a total of 137 respondents to the questionnaire. Next slide, please. The primary findings that we found were when asked what complaints have been reported to the Ombudsman program with regard to opioid misuse or use, the top two complaints were drug diversion and medication unaccounted for. However, one of the themes that really was just prevalent throughout the questionnaire, and as we get to the resident interviews that we'll share those results with, the most reported negative effect from reducing or removing opioids was unmanaged pain. And the third primary finding we saw was a significant need for education and training for both ombudsmen and for residents. Next slide, please. We asked ombudsmen if their programs had received complaints regarding opioid misuse, and as you can see, 53% said yes, while 25% said no. 22% did not know if their program had received complaints involving opioid misuse. Next slide. I find this particular chart interesting. The question was, in the last year, what is the most common type of complaint related to opioid use or misuse that you have received? And the individuals could select all that apply. And as you see, the most frequented answer was medications unaccounted for. Second most was drug diversion. And we have 19% didn't know, 18% said other, and 15% said medications stored incorrectly. Almost 20% answered that it was not applicable. However, what I found very curious, under the other, individuals were asked to further explain why they may have chosen other. And across the board, the other comments included physicians reducing dosages, that residents were taking off opioids completely, and residents had an increase of pain due to the dosage reduction or eliminating the medication entirely. Next slide, please. In response to the question, has your program received complaints involving inadequate pain treatment for residents, 98 respondents said yes, which is about 72% of the respondents said yes, while only 19 respondents said no and 20 said they did not know. So this slide reflects whether or not opioids are part of the picture. There's still a big problem with treating residents' pain. Next slide, please. With the question, have residents raised concerns with you about opioid prescriptions or lack thereof? 104 of the responses said yes, residents have raised concerns. The two answers that they could have selected were that they had a concern about actually using opioids or concerns about their inability to access their pain medication. And so of those two, 104 said yes, while only 44 responses said no. 9 respondents were unsure. One respondent wrote, residents have reported that they are in so much pain that they have attempted suicide due to their untreated pain. Another resident reported that she has to go through so many hoops just to get relief from her pain. For example, she has to go to the doctor weekly or every 2 weeks just to get a script for her chronic pain. She's in her 90s. Another respondent wrote, residents who have been prescribed opioids by doctors for many years are now being told that the quote-unquote the government is prohibiting doctors from prescribing them anymore. Doctors generally do not have much in the way of effective alternative pain management programs to replace the opioids, and the residents are very unhappy. And yet another respondent summarized the concerns by stating, I had one facility that a nurse was exchanging the opioid pain meds for Tylenol, and then another resident who was concerned that she would get addicted because of what she saw on the news. Then I had a veteran who was denied the drugs because of the crisis, but he had been on the same pill and milligram for over 15 years without any abuse. So those were responses that Ombudsman had shared with us within the questionnaire of concerns that they were hearing from residents that they're working with. Next slide, please. We asked if, to the Ombudsman's knowledge, have the recent state and federal efforts to reduce opioid use affected prescribing practices in the facilities you visit? While most respondents answered that they did not know, 40% of respondents indicated that physicians are either less likely to prescribe opioids or will no longer prescribe opioids. Some indicate that it is harder for residents to continue to get the same dosage that was prescribed to them previously, all leading to reported uncontrolled pain and suffering for residents. Next slide. In terms of alternatives to opioids to manage pain, most respondents said they did not know, but those that said yes indicated some of the alternatives reported were for example, yoga or massage, meditation, physical therapy, counselors, addiction programs, and pain management clinics. Next slide. We also asked if Ombudsmen were aware if residents who were seeking admission to a nursing home facility or an assisted living facility were being turned away if they were taking medication to treat opioid addiction. And as you can see, most of the respondents did not know, while 40% said yes and only 40% said no, while only 7% said yes. Next slide. On training and education, 50 respondents said that they have received training, but 87 said that they have not. Several ombudsmen who responded yes to having received the training report that the training was provided outside of the ombudsman program by federal or state agencies and online webinars. Very few reported receiving training through the ombudsman program. As you can see with the chart on your right, very few, only 8% of the respondents stated that their ombudsman program has developed a training program, and you can see 92% that they have not. Okay, next slide, please. I would like to now focus on the findings that we had from the resident dialogues that were conducted in, I believe, 7 states. So if we can go to the next slide, please. We had a discussion with resident groups / resident councils, and of all of them, we had 105 residents participate in 7 different facilities in 6 different states. And I find these findings are quite interesting. In terms of, next slide. In terms of a lack of information, we asked, our first 2 questions were, has anyone, your doctor or facility staff, talked about issues with prescribing opioids or any changes they might be putting in place around use of opioid medications in the facility? And the second question was, has the resident council had any discussions or expressed any concerns about the opioid crisis? Most residents from all 7 facilities answered no to the first 2 questions. The few who answered yes said their doctor mentioned alternatives or limiting pain medication in response to the resident's history of substance use disorder. Some residents were aware of the opioid crisis, but reported that they were not informed by the facility staff or doctors about changes in prescription practices. Next slide. We also asked residents, does your doctor, a pharmacist, or nurse talk to you about the benefits and potential negative effects of your pain medications? Again, most of the responses were no. One resident said, not really, my doctor is invisible. Another resident who had said yes explained that her doctor said for her, the good outweighs the bad. And the resident and her doctor are monitoring her response to the medication to make sure she's not over-medicated or has any other side effects. So she's having a good experience with her doctor and feeling educated about it. But again, most of the responses we heard were no. Next slide. In terms of asking the residents if your doctor changed medication because of concerns about prescribing opioids, most residents reported no changes in medication. One resident requested that the doctor reduce her dose because she felt like a zombie, and the doctor did oblige. Another resident said his doctor suggested lowering his dosage, but he refused, and again, the doctor obliged. One resident was referred to a pain clinic, and she was happy with the outcome. Another resident said that their physicians did not change their opioid prescription, did change their opioid prescription to Tylenol, and it was not effective. So we got kind of mixed results in terms of responses to that question. Next slide. When we looked at non-opioid treatments and what were the effectiveness of these treatments when we asked residents, in terms of physical therapy, residents were saying that physical therapy can help, but there's a limit to what Medicare and insurance will pay. Other residents mentioned nerve stimulation, such as TENS or the transcutaneous electrical nerve stimulation. And they said that the TENS can help and can be used along with pain medication. Others said they were offered yoga, but yoga in their facilities was offered very infrequently. Some residents said massages can help, but the facility won't always allow massage therapists to come in. And in terms of other non-opioid pain medications, the non-opioid medications don't work for those who were previously taking opioids. And again, these were the responses that we heard from the residents after being asked. Next slide. So are residents getting pain medication when needing? For those that we asked, most residents reported that they do get their medication on time or when needed. However, residents from 4 of the facilities reported that they've had to wait too long for their pain medication, reporting hours, even days late. Residents in 3 of the facilities reported that the facility does not order the medication from the pharmacy in a timely manner, resulting in residents going without treatment. One resident was supposed to have his pain patch changed every 3 days, but went a week without a pain patch. Other residents said that they have to be assertive to get their meds. One resident says he's supposed to take it every 4 hours, but is only able to take it every 6 hours, and he's been made to wait in pain when it wears off. Next slide. When we asked residents if they had concerns about opioid misuse in the facility, 4 out of the 7 resident groups said that they had no concerns. 2 resident groups said yes, and here's some of what they said. One said a nurse was diverting fentanyl patches for herself. Another said that they're concerned because of the high staff turnover, and further saying that residents expressed worry that caregivers might be using drugs. Some of the quotes were from residents. Some days they are with you, but not always. Sometimes we'll joke around ourselves and say, wonder what they're smoking today. And a final quote is, they should drug test around here. Interestingly enough, no resident group raised any concerns about resident addiction in their facility. So now I'd like to turn it over to Lori to continue on our conversation about drug diversion concerns.
Thanks, Jamie. Next, thank you, Katie, for moving on to the next slide. So we talk a lot about drug diversion, and it came up in the questions that we heard back from the Ombudsman and in a lot of the research. This is the term that's been used, but more often than not, what we are really talking about is theft of the drugs or the drugs not being used for their appropriate purpose. And so certainly, I think it's important to acknowledge that as we are, looking at this issue in terms of what's really going on here. And when we're talking about drug diversion, we're looking at switching the pain medication for other pills, which is an example of the theft that's occurring, not just like taking the whole medication packets or bottles or whatever, but actually switching them for other drugs that may or may not be prescribed or appropriate for the individual that's then receiving them. And in fact, this is an issue that I spoke with the daughter of an individual whose nurse had been stealing her mother's pain medication recently and was actually switching the medications out and putting different kinds of meds in there that were being given to her mother and causing other serious health issues. And it's very serious, not just the pain that the person was experiencing because she wasn't getting her pain medication, but also the effects of these drugs that were being given to her for which she didn't need them. And so certainly I think we can say that that's a form of abuse that's taking place right there. But other examples of the theft or the diversion includes forging of paperwork, people being given the drugs in the charts when actually they weren't being given the drugs, direct stealing, either the pills individual pills or whole bottles or packets of pills, and the signing out of the as-needed or PRN pain medications purportedly at the request of residents, where the individual, the nurse or whoever would be signing out the drug said, well, the resident asked me for the pain medicine, but when they went and talked with the resident denied asking for it and, in fact, had never received it. And those are some of the examples of the theft that we certainly were seeing with specific research that's been done. Most recently, I included 2 articles here that will include the links to in the materials that had come out, but one is related to a recent case where a home health nurse was charged with the theft of the opioid medications and actually was convicted. And as we know, too many of these cases are not only underreported and underinvestigated, but rarely do they get to this level of conviction. And so this is an important situation where the drug theft was actually caught and the perpetrator prosecuted, so that not only did the individual whose medications were taken hopefully get some sort of justice out of this, but also it will prevent that person from doing this to other people in the capacity as a nurse, at least. And then also another article looked at a recent study done by Dr. Ilan Caspi from Minnesota, who looked at deficiency citations in assisted living facilities in the state that related to opioids and theft of medication. And he explored some of the different ways that that the drugs were being stolen from the residents, and they include several of the examples that are listed here on the screen. But so while these 2 examples are not nursing home related, like the rest of our study was in this particular case, they do carry over into what we were hearing from ombudsmen throughout the information that we were gathering from them, and also that we're hearing through other research and studies as well. It's a very serious problem. So as we were thinking about what we wanted to get out of this project when we were planning it, and next slide, please, Katie, we really were looking at not only what was happening out there in the field with respect to the impact of this issue on residents, but what is it that we could do to support residents and ensure that they are getting the appropriate care that they need, that they are experiencing high quality of life, and looking at what types of information and resources did they need and want throughout this process. Because what was clear from the information that we gathered in the dialogues with residents was that certainly some of them had heard about this issue. I mean, there were various levels of how informed they were about what the opioids were or what the crisis was all about and how it impacted them. But for too many of them, people were not talking to them directly about what the impact was on them, including if there were direct changes in prescribing practices, why that was, why there might have been some changes to the medications being prescribed to them, what alternatives might be. Those were some of the things that were not readily, that's some of the information that was not readily available to them. And so that was a serious issue. But also as advocates for residents and that are experiencing a variety of these issues, certainly we need to be thinking about and talking about how we can best support them. So next slide, please. As we looked at the information that we gathered from the ombudsman and from the residents, you're not going to be surprised at all that several themes arose from that, including changes in medications from opioids to non-opioids. We heard frequently that instead of the opioid pain medication, they were substituting out regular over-the-counter medicines like Tylenol, and many of the residents had said that that switch just on its face was not very effective, and potentially there was not good pain management or switching. to that drug in order to determine whether that was an appropriate course of action for the resident. Changing in prescribing practices, often, despite the fact, often because of changes in standards or changes in guidelines that have been issued by Center for Medicare and Medicaid Services, for example, or changes in guidelines from the Centers for Disease Control, that has resulted in some changes in prescribing practices, even if they don't necessarily specifically apply to nursing homes. It's just more broadly been impacting some of the prescribing that's taking place for residents in nursing homes. We have been hearing, as I mentioned, from residents that they are not being fully informed of why the changes are being implemented and affecting them. Insufficient access to alternative treatments was an important issue. There are other treatments that studies have shown are as effective or even more effective than simply medications alone, but unfortunately, particularly in nursing homes, there was not sufficient access to those treatments. And Jamie listed a number of those, including massage or physical therapy or acupuncture. They're just not available to residents. And so while I think that the residents that we talked to would be interested in alternative treatments as they think about how to best treat their pain, unfortunately, it's not been something that's necessarily been offered to them. The theft and diversion of medications certainly has been a big issue, and one that I think we'll continue to hear more about. It's certainly an area that needs specific attention by long-term care facilities, as well as the licensing agencies that oversee them, and the vigilance of residents and families in terms of assuring that the medications they're receiving are appropriate and the right ones for them. There was a clear need for more information and communication that was coming out of the residents. And all of the information that we essentially got, I think, from the residents and the Ombudsman really pointed to the fact that there is way too much unresolved pain that is occurring in long-term care facilities and experienced by the residents. It's not being appropriately treated. And as we're looking at changes in the way pain medicines are being prescribed and used in this country, we need to remember that individuals such as long-term care facility residents with chronic pain need some particular attention in order to assure that their needs are being met and that their pain is being appropriately managed. Next slide, please. So as we looked at what are some of the areas of advocacy that we need to be looking at and thinking about in terms of supporting residents, first of all, we wanted to point to the issue of proper assessment and care planning. Certainly, as we know, that is the cornerstone of all residents receiving the appropriate and individualized care that they need, that their proper assessment of pain is occurring on a regular and ongoing basis, that care planning is done in order to help manage that pain, and it's not a one-and-done type of issue. If the care plan is not working or the pain is not being addressed, then that means go back to the drawing table and look again at what strategies can be implemented in order to make sure that the resident is getting the individual care that they need. But looking through this process also at proper monitoring of the medications that they're taking, any side effects, are they too dependent on some of these drugs, and are there alternatives that can be incorporated into their pain management while they're being tapered off. Opioids are being used instead of opioids, but certainly that is a cornerstone of ensuring that the residents are getting the care that they need. And as ombudsmen, as family members, as residents yourself, certainly continuing to raise the issues and the need for care planning in order to assure that you're getting the care that you need is critically important. Understanding that all residents charts and medications are to be reviewed on an ongoing basis by a long-term care pharmacist is certainly a point of advocacy as well. On a monthly basis, the residents' medication charts are supposed to be reviewed according to the regulations by a long-term care pharmacist, and any areas of concern or abnormalities in their medications are to be raised with the physicians who must then respond to and address them. So certainly, you know, again, looking at the assessment and care planning process, asking for review by the pharmacist, asking about the drugs that are being prescribed for you, what they're for, are there alternatives to them, and what the pros and cons are of each of the drugs is certainly an important part of the advocacy process, whether you are advocating for yourself or for your family member, or are an ombudsman or citizen advocate working with and on behalf of residents. Looking at alternative pain management strategies, how can they be more available to the residents in long-term care facilities? We have heard some of the residents talking about having access to pain specialists or clinics. That has been helpful in treating their pain, and in some of the alternatives that we've talked about today, and advocating for incorporating these alternatives into the pain management certainly is an important point of discussion with the nursing home, an important point of advocacy in your community. And for residents with potential substance use disorders, how can those residents be supported in tapering off of the drugs that they may have some addictions to or dispensations towards, incorporating appropriate protocols for monitoring the use of the medications, incorporating the alternative treatments, and also incorporating monitoring of the drug use for those individuals. Next slide, please. As advocates, we certainly need to be thinking about what the facility's responsibilities are in this particular situation. They are required to have policies and procedures around proper care and delivery of care to residents, proper oversight of drug regimens, and maintaining the proper provision of medications to the residents, and that certainly needs to be assessed and evaluated on an ongoing basis to ensure that the drugs are not being stolen and diverted, and that residents ultimately are not receiving the pain medicine that they need. So proper monitoring and oversight by the facilities, by their management staff, is critically important on an ongoing basis to assure that the drug thefts are not occurring, or if they are occurring, that they're caught and dealt with as quickly as possible. Staff education and training, not only about providing care for individuals that may have substance abuse issues, but also in terms of education and training about opioid use, about pain management, about providing individualized care for the staff, for the residents that they're caring for, is critically important and should be part of the facility's protocol in providing care for the residents. And then also implementation of alternative care and treatments as necessary. They are more widely available now more than ever, and incorporating them to the greatest extent possible so that residents can access them as part of their care planning process is certainly important. As advocates, it's important also that we look at coordination with state and local elder justice task forces and law enforcement when we have concerns about drug theft, about opioid misuse, as there are efforts going on across the country to address this issue, to look at how to prosecute situations where there has been the stealing of drugs, where there has been the diversions that we were talking about earlier, and also some of the replacements of taking the drugs out and substituting with other drugs. There are real serious issues there that need to be addressed and evaluated by these these elder justice task forces and law enforcement. And so as advocates, staying in communication with them and talking about collective strategies for dealing with opioid issues in your communities certainly is a way to help affect change in those areas. And also really looking at the communication with residents and family members, how to best communicate with them about what the issues are around opioid use and misuse, what some of the signs are of misuse, or what things might raise concerns about opioid misuse, talking with them about alternatives to opioids, and also educating them about proper pain management and what they can do to help themselves with control of pain and how they can help their loved ones in this situation. But certainly keeping the residents and families informed and part of the conversation will then help, I think, affect change all around with respect to the use of these drugs. Next slide, please. What was really important, we felt, as part of the discussions that we had with residents was, again, looking at what information and tools do residents want in terms of thinking about this crisis that we're dealing with as a nation that is affecting them in terms of their access to medication, in terms of their access to relief from the pain that they're receiving, and also the impact that it could even be having on their families and communities. So what do they want to know? And these next couple of slides were some of the issues that were raised that the residents wanted more information or resources about. Questions for residents and families to ask their doctors. They really want to be involved and engaged in their care, in the prescribing practices. They want to know what it is that they're being given and what the risks and benefits are. What are the side effects? They really want to know what that impact is on them, what the drugs are, and what's the best option for them in order to treat their pain, and how they could best go about getting it. Questions that they could ask with the nurses. Every time they're receiving medications, they should be and could be asking, what is it that you're giving me? How would they recognize what the pills are that they're receiving? What's it for? How much is the dosage that they're getting? Why am I getting it now? By asking questions and being involved in that process keeps them not only engaged, but helps have another check, certainly on the system of ensuring that they are getting the proper medications as well. Next slide, please. They also wanted information that they could use to understand, again, more about what are the drugs that they should be concerned about. How do they know if they're taking the right dosage? How do they know what the signs of dependence or addiction might be, if they should be concerned about any of the drugs that they're on? And more information just generally about opioids and what they're used for, what the benefits are, and how long is too long, if at all, to take them. Residents are not being given this information, and so it's important, again, that they continue to be part of the conversation so that they can make informed decisions and give informed consent for the types of medications that they're being prescribed. They also wanted to know where could they go for more information as well, and where can they go if they have concerns about the drugs that they're taking, if they have concerns about their pain levels not being managed. Who can they go to for help and for more information, both within the facility and outside of the facility? And so these are important questions that they're looking for more information about. We are in the process of developing a resource for consumers that will incorporate all of these questions and information that the residents have been seeking. And once that's complete, we will make that available to you all for download so that you can share it with the residents in your communities as well. Next slide, please. We also asked residents if they had any words of wisdom for others in terms of thinking about what the how to address the medications that they're receiving, any concerns that they may have, and some of the tips that they shared with us, we think are universally true for all of us. We should incorporate these words of wisdom whenever we are taking medications ourselves. And so certainly some of them include becoming familiar with your medications and what they look like. What does that pill look like that you're supposed to take in the morning, and how many times a day are you supposed to take it? And when you are given the medications by the nurse that's bringing them into you, take a look at them and do they look right? Particularly since, as we heard, one of the mechanisms for stealing the drugs is supplanting them with something else. So really looking at and carefully looking at what's in your cup that's being given to you when you're given your medications. If you don't recognize a pill or something just doesn't look right, you need to be asking what it is and what it's for. Because you should not be just randomly given new medications. By staying involved in your care and your care planning, hopefully you'll also be told what new prescriptions you're being prescribed before the medications are actually being given to you, so that you can assess the pros and cons of taking that medication. So asking questions about pills that you might not recognize, what is the drug for? If it doesn't look right, you certainly have a right to be asking about it, and asking not only the nurse, but asking for your physician to give more information if necessary and appropriate. And certainly the residents said that they have the right to know when and why a medication or dosage has been changed, and to speak up if they have concerns about changes in their medications, or if something's been changed and is no longer effective. So that certainly is important. So we don't have much time left, so I'm going to, Katie, if you could move 2 slides out. We do have a link to some additional, if you could go 1 more slide, thanks, Katie. If we do have some links here to some additional information about opioid use, information about alternatives to opioids, prescribing practices that you can access to share and review with the folks in your offices and in your facilities. As I mentioned, we are continuing to work on some additional resources that we will be sharing over the next few weeks that we'll send out to you all as well, and we'll make available on the Consumer Voice website. So with that, I think we might have time for just 1 or 2 questions. And so with that, I'm going to ask Jamie for help. Jamie, have you identified any, were you able to look at any of the questions to see if there are any
Yes.
that we have time to answer?
Yes. Some folks were asking if they could get copies of the questions of the surveys for both the Ombudsman and the resident councils.
Yes, so the questions that we addressed here in the slides will be in the slides that you can access, and they're in the link to the chat feature, and they will be posted to the Consumer Voice website after the webinar within the next day or so, and you certainly can pull from them. And then as we develop the consumer resource, many of them will be included in that as well. So we'll make that available to you.
Okay.
I do see one question: is it more lucrative for facilities to keep residents on opioids than to provide other pain management strategies? Not sure about how lucrative it is. I mean, certainly there are varying costs for the drugs that are being provided to the residents. So that certainly could be a factor that is taken into account when the drugs are being prescribed, because we certainly have heard incidences where facilities, because the cost of the drugs is part of the daily rate that facilities are paid, particularly related to Medicare or Medicaid, facilities have balked when a very expensive drug has been prescribed for a resident and they don't want to pay for it. So that certainly can be an issue, but certainly having conversation with the physician about what the most appropriate treatment is for the individual is critically important in this process. And with that, unfortunately, I think we're out of time. We're at the top of the hour. We will go through the questions, and if there are any that we can send out answers for, we definitely will try to do that. I want to thank Jamie for her presentation today, as well as Eden. Thank you for joining us and for your presentation today. We will share with all of you not only the slides, but the links to the information that we've discussed throughout. And as I mentioned earlier, there will be more to come from the Consumer Voice and the Ombudsman Resource Center in the next few weeks. So check back on our website about this. And thank you all. Send us your questions and information that you may have developed on this issue. We will be sending out right after the webinar a brief survey, an evaluative survey about the webinar that also asks some additional questions about what types of information you as advocates or as family members or residents may also want to see, so that we can take that into account as we are, again, pulling together the information that we'll be sharing. So please take a moment to respond to that. And thank you, Katie, for managing the logistics of the webinar today. And with that, we will close for the day. Thank you so much, and have a good rest of the afternoon.